Thank you so much, Joanna. And before I introduce the first conversation, a few housekeeping notes. First, we would love you to join the conversation on Twitter at Atlantic Live, all one word, and use the hashtag Atlantic Explores Cancer. And we want you to be a part of the conversation in this room as well. So we'll take your questions. We'll have people with microphones after each of the sessions. And so now, let's get started. In our first session, we'll look at the Pittsburgh story and the role of the medical community in the city. And I'm delighted to welcome to the stage Dr. Stanley Marks, chairman of the University of Pittsburgh Medical Center's Hillman Cancer Center. And here to lead the conversation is my colleague, Steve Clemons, Washington editor-at-large at The Atlantic. So Steve, the floor is yours.
Thank you, Emily. Thank you. Hi, folks. I don't know if I've met all of you. I tried to meet a good number of you before the session began because you're going to be stuck with me for the next hour. And then in 3 sessions, we're going to have, we call it Atlantic Shane. He's pretty cool, but there's some other cool people coming behind him. But I just want to just say a shout out because we've gone into these communities and I've always been fascinated by how many different angles there are to this story. Maybe that doesn't impress you, but it certainly impresses me. I met, where's my friend from is it Stacy from Pittsburgh Community Services? Tracy from Pittsburgh Community Services. I met her. Where are the folks for Kesem? I didn't know anything about Kesem. They're the first ladies I met when I came in here. They do this camp for children who have parents with cancer. We met. Tell me where you're at again. You're with a lung screening. Right. Whatever that is, that's cool. But I love that you're doing lung screening, lung cancer screening. And then we've got. Oh, where was I? Was also looking for. My pediatrician who said, you know, the environment here sucks and we need to get it. Where? Yeah, right there. Okay. Yeah, you look like you're known here. So anyway, I just wanted to say, let's spend some time. Let's make this your forum, your town hall. I feel like, in a way, Dr. Marks, if we just locked everybody in this room and said, we're not leaving until we fix this, that might be cool, right? So, but how long have you been in this business?
I started practice in Pittsburgh in 1978.
So on a scale of 1 to 10, how do you think you're doing in beating cancer in this community?
I would say an 8. Obviously, I think we're doing very well, but we do have a way to go. I think overall the cancer care in this region is excellent, particularly those affiliated with UPMC, Hillman Cancer Center.
You said recently that the developments that have happened technologically in the last 2 years are such huge game changers that it completely changes the possibility of what's coming. And you know, I love Pittsburgh. I was telling some folks from the Pittsburgh Business Journal that I've enjoyed coming back here. I've never come to Pittsburgh to sort of look at the health dimensions. And if we were here in 4 to 5 years to come back, what do you think is possible in terms of the overall levels of incidence?
Well, hopefully the incidence will go down. I mean, there are certainly several components in terms of prevention that does take time to impact the numbers of cases, but we have to increase our screening, which I'm happy to talk about. But
she wants to do that too, right?
Yeah.
What's your name? Viv. Yeah, she's ready.
Okay, great. You know, we've been very active in lung cancer screening here. I think many folks here know about the PLUS study, which was the Pittsburgh lung screening study at UPMC, which is the largest screening program in the country. About 5,000 patients have been screened, and I think about 300 cases of lung cancer have been found. And we were one of the sites for the landmark study that actually showed that lung cancer screening made a difference in terms of mortality. I think we were the 8th largest accruer to that landmark study. So we have been very focused on screening, but you know, clearly we have lots of research going on at UPMC Cancer Center in terms of new and better therapies.
You know, I want to hear about what you're building in immunotherapy, what you're building is, but I guess the thing I want to get at, because lung cancer is such a tricky discussion to have, and we're going to be talking about that here today, is on one hand, you've got these exogenous factors which clearly make an impact, whether it's smoking, environment. There are a lot of folks I've just been talking to in just the last few minutes who've been sharing with me, of course, the legacy of this area in fossil fuel extraction and, you know, industry, particulates in the air. And on the other hand, you've got lots of scientific development that is coming online to help people who are afflicted, who who shouldn't get a death sentence from getting these things. So where do you get the most impact? Do you get the most impact from scientific development, or do you get the most impact from better environmental stewardship?
Well, there are several factors that cause lung cancer, and certainly the environment is part of it, but we know smoking is probably the #1 risk factor. And so, smoking cessation is a major focus for us. We actually have a very unique program at...
I don't mean to interrupt you. I drove here from the airport, and I decided to take account of the number of folks I saw smoking in various ways, in cars. I went by the UPMC Children's Center. It said, "Do not smoke on this lawn," right around the corner. The folks that are there, 47 people between here and this spot were smoking in this area. I just wanted to kind of note that as it's not indicative of anything other than my drive from the airport, but that's pretty staggering.
Well, it's interesting. We actually track this in our region, our epidemiologists, and it's really a problem in the African American population. And if we look at our 5-county area, about 15% of Caucasians smoke, whereas about 27% of African Americans. And that's reflected in their higher incidence of lung cancer and lung cancer mortality. And so it's particularly in those communities where we're trying to get in and educate and try to get folks to stop smoking.
So people develop lung cancer, and as I understand, I really am interested in the screening question. If you were to transform, if we were giving you a lot of power and a lot of money and a lot of marketing, what would you do that we're not doing today? I just learned again from my friend here on lung cancer screening that if you're correct, and I haven't done my fact checking with the Atlantic, always does fact checking, so I'm admitting to not, but you said that 55 years and older in Medicaid will cover, but as I understand it, lung cancer is not really associated with age. And and I think we're going to talk about that coming up. So how mismatched are our sort of health policies and supports with the reality of how lung cancer hits us?
Well, the screening study actually involved patients 55 to 75, but we do see lung cancer in younger patients. Age is still a risk factor for lung cancer, but unfortunately we see lung cancer in 30-year-olds and 40-year-olds. But I think that the major focus should be, in terms of screening, clearly on those that are at the highest risk and in that age group who've smoked for 30-pack years or what have you.
And what's going on the environmental front here?
Well, it's a good question. We have, the history of industry here. We have an issue with radon. And in fact, we've been able to identify by zip code where the highest concentrations of radon are that are clearly associated with lung cancer. And then,
so there's no doubt about that?
There's no doubt in our mind, yes. And diesel particles in the air. What's interesting again is that at least in this region, the diesel particle risk or added risk of lung cancer is primarily in African Americans. We're not seeing it in Caucasians for some reason. And the same thing with benzene, which is another problem in our area. It seems to be primarily a risk factor in the African Americans, not in the Caucasians. So these are the sorts of things that we're looking at. And then clearly, we've got to get to those communities. I saw Lynn Robertson here. So, there's Lynn Robertson. So for those of you who don't know Lynn, she actually spearheads our entire community outreach program in terms of education and prevention. She does a great job. But to your earlier question, yeah, we could use more money and have more Lynn Robertsons getting out into the communities.
When you raise these issues and I sort of look at someone in your position and you see so many people who come through, you probably have your own data sets, you're able to kind of look at both environmental factors and as you said, you've been able to look at different demographic groups to impact that. Is there a point at which you become a political player and you've got to go tell the county, the city, the state to clean up their act?
Well, there is, and we actually have a very good county health department that we work with closely in a variety of areas. This is really a long-term issue in terms of cleaning up the air. We've been working closely with them. We've worked with them in terms of the HPV vaccine,
right.
And smokeless, e-cigarettes. We are actually successful in working with the county health department to not allow e-cigarettes in the public environment. And that was a major coup for us because we do know that there is some associated risk with e-cigarettes as well.
One of the things I've been interested in is Sean Parker. Do you know Sean Parker? Sean Parker donated a lot. Maybe I hope I'm not screwing up his name. He was the Napster guy. He was on the board of Facebook, and he took about $500 million and he put it in different places to sort of support immunotherapy research. And as I understand, has anybody else heard of Sean Parker? Yes, you have. Okay, good. I just want to say, God, did I mess up his last name? You guys know who Sean Parker is, right? So that's okay. I'm not culturally literate either on many fronts. But Sean is a guy who came out of the high-tech sector, has taken a lot of money, and originally I had serious doubts about his philanthropy. I thought he was trying to corner the market when it came to looking at forward-based immunotherapy drugs and doing this, but he put a lot into USF, a lot into the pen, and I imagine he's been out there and helping to support some of the stuff the University of Pittsburgh may be doing. But I'm interested in whether the world of immunotherapy, and as you get even deeper into that, the world of precision medicine, is the magic drug that we've been waiting for. And I'd like you to share with us, because a lot of this gets tossed around with a lot of specificity. But I know you've got a new center, and you're also investing hundreds of millions of dollars in basically becoming a competitor to BMS, as I understand it. But how is that world evolving, and how will it change the conversation we're having here today?
So there's clearly been a paradigm shift in how we think about cancer and treat cancer. And what's interesting is this whole idea of immunotherapy isn't new, but many people doubted it. And actually, Ron Herbermann, who started the Pittsburgh Cancer Institute in 1985, believed that immunotherapy was important in terms of fighting cancer. That being said, it's only been in the last few years where it's been validated.
So can you do me a favor, and
yes.
just because we have a lot of lay people in this room, explain immunotherapy rather than just having a
Sure. So, well, there are actually several types of immunotherapy, but basically the concept is, why do we get cancer in the first place? And in many cases, it's because our own immune system fails. Particularly as we get older, our immune system fails, and that's why age is the #1 risk factor for cancer. As you get older, your immune system starts to fail, and cancer can develop as a result of mutations that occur. And this idea of immunotherapy is actually to try to use your own immune system to fight the cancer. And it can be done in several ways. The most popular form today are what are called checkpoint inhibitors, and you've seen the billboards up and down the road. But there are also other forms of immunotherapy. For example, CAR T cells that we're learning more about for blood cancers. And all of these forms of immunotherapy are directed at using your own cells, your own lymphocytes, to turn them on to fight the cancer. And the thing about it is, to some extent, maybe we're overexcited, because if you look at the individual cancers, in a lot of cancers, immunotherapy only works 20 or 30% of the time. Now, in some it's higher, but in many it's only 20 or 30% of the time. And so one of the things that we're very interested in is identifying the people in whom it will work, because the other 70 or 80% are getting it. These agents are extremely expensive, and there should be another option for those patients. And so, yes, we're very excited about immunotherapy. UPMC, as you know, has committed $200 million to this immunotherapy center, not just for cancer, but we think it's critical for the aging process, as well as organ transplant, where you can induce tolerance by altering the immune system so that organ transplant becomes safer. And so we have a long way to go. We're very excited about it, and frankly, this is probably the most exciting time in my career as an oncologist, but we have a way to go.
And how do you graft on the precision medicine field, which is also booming right now, where you're looking at the genetic disposition of people across different things? Because I find that, as many of you, how many of you have had a family member or even yourself, have you been close to cancer? Just about everybody, I bet, right? Well, I lost my mother a few years ago, and I was shocked at how illiterate I was and how illiterate essentially most of the doctors in around Bartlesville, Oklahoma were on anything modern. And when I began looking at questions of precision medicine, immunotherapy, which have come out and really helped in breast cancer, or Jimmy Carter's case. So I'm just sort of interested in one, the science of it. And then the other question I have is, what do you have to do to market those advances out to doctors around the United States who seem to be, many of them, if I may, not as literate as you may be in this? I mean, there seems to be a problem. Do you agree?
There's definitely a problem. And part of it is no fault of their own, but when you're a community oncologist, you're treating everything. You're treating lung cancer, breast cancer, colon cancer, lymphoma, and the list goes on. And with all of the developments that are happening so rapidly, there's no way that anyone can keep up. And so for example, at the Hillman Cancer Center, our physicians might see 1 or 2 types of cancer. But if you're a community doc, you don't have that option. One of the things that we've done at UPMC is basically created what are called pathways that standardize care. So, if a patient comes in with a certain type of breast cancer, a certain stage, there's a pathway that tells you what you will do. And that's the way, we manage our network to assure that the quality of care delivered 100 miles from here at a UPMC site is the same as they would get, at the Mecca, if you will. But, if you don't follow pathways, it's very hard to keep up with these cancers. And so there's, clearly a lot for physicians to learn. And as I say, it's almost impossible to keep up with all unless you're using pathways. Now, the National NCCN has created what are called guidelines that are helpful. And those are available to oncologists, but even some oncologists don't reference those. So you're right, it's clearly an issue.
When you look at, you're going to go to the audience here in just a minute, but when you look at what you need to accomplish out here, what thing are you missing the most? What would help you more than anything else achieve the goals you have for a much healthier community?
Funding.
Funding.
Yeah, I mean, we have, I'm sure everyone knows that, cancer funding has really not even stayed level. If you look at the rising costs of performing research, the National Cancer Institute budget has really been down, if you will. And so we're more and more dependent on philanthropy or other sources. And we have some brilliant young researchers with great ideas that can't get funded. People don't realize that for every 10 grants that get submitted to the government for funding, 1 gets funded. And we have some really remarkable researchers who cannot get funding. And so, I think if we were able to get those dollars through philanthropy or other sources, that would move science along a lot faster.
I am going to go to you guys in a minute, but I know that you have gotten, when I joked facetiously about competing with BMS, I wasn't entirely facetious. You're going to invest in drug development trials, clinical trials, and try to help innovation, i.e. companies, get over what they call the valley of death in funding. And that's a very rare thing, as I understand it, out there. So why are you doing that when almost no other institution is doing that?
Well, first of all, we are partnered with BMS, and actually many of the original immunotherapy trials were done here in melanoma. But we think that, first of all, we could, for example, CAR T cells is a good thing to, we believe that with our experts, we should be able to produce our own CAR T cells. I don't think it's any secret that, these agents are extremely expensive, and how you attribute a price tag, CAR T cells cost over $400,000 that we actually have to pay to get CAR T cells. We think that if we can develop those CAR T cells with our own expertise, we can certainly reduce costs and probably come up with a better CAR T cell. That's just one example. But we're certainly partnered with industry. Industry's our friend. They support a lot of our research efforts. But at the same time, we think that we can, with our scientists, we can commercialize our own research discoveries.
So let me open up the floor. We've got one of the great cancer leaders of the country here. Let me ask for questions, comments from all of you. I'm going to go to my lung cancer screening lady. Yeah, right here. I know you want to say something.
Hi, I'm Susan Weedo. I'm a nurse navigator for Heritage Valley Health System. We're a lung cancer screening program for Heritage Valley Beaver and Heritage Valley Swickley. We're a Lung Cancer Alliance Screening Center of Excellence. We started the program about 2.5 years ago. We've screened about 1,400 patients, initial lung cancer screens so far. We've captured many patients with stage 1 cancers, which of course the patients just needed surgery but didn't require chemotherapy or radiation therapy.
How are you getting them at stage 1? And sorry to interrupt.
Well, one of the criteria points is the patients have to be asymptomatic. So it's been a lot of physician education as well as community education to get the patients. It really starts with the primary care physicians, getting them to like best practice. Like if you come in, they're going to speak to a female about a mammogram or the colonoscopy, that we need to flag the smokers and get the patients to that qualified to get them screened. So every month, like when I started the program, we had maybe 15 to 20 patients a month. Now we have over 100 patients that come in for their screens. We also track like we categorize in the lung rads. So if a lung rad's 3 or 4 patient comes in, we track them, make sure that they get to the surgeons or the pulmonologists. So,
Wow. Well, thank you.
It's just been great. Thanks.
Well, do you have a question for Dr. Marks?
Oh, yeah. Yes,
I did give you an opportunity to. That was a wonderful advertisement.
Yes,
Yeah.
right. Thank you. Yeah, that's Heritage
I
Valley.
want to go, yeah.
So anyway, I just think that, like, as far as just the earlier the diagnosis, the better treatment options the patients have. Do you obviously see the importance in early lung cancer screening?
Sure, of course. Yeah, I'm a big proponent, and I think, obviously UPMC has been at the forefront of lung cancer screening, but, I think it's great what you're doing in the community. Actually, your oncologists at both institutions are part of us. You have great oncologists at Beaver and Swickley. But that being said, we would like to see this happen more out in the communities, and it just hasn't. And it's great that you've taken the initiative, and you're obviously in an area where industry has been, a long-standing problem in terms of pollutants, but also there's a heavy smoking population where you are, based on the zip codes that we've studied.
Right here, yes.
Thanks. Hi, I'm Michael Maxon. UPMC does very well in enrolling people in clinical trials, much better than most other hospital systems. What do you attribute that to?
Thank you. That's a great question. I should have asked that.
Well, I think a couple of things. As I mentioned earlier, we have this large network of sites, Beaver, Swickley being 2 of them, and we open many of our clinical trials, not all of them, but many of the clinical trials to the community sites if they have an interest in participating. And when we look at the total number of people that we put on clinical trials, somewhere between 25% and 30% of our total accruals come from the community. And so it's great for the patients. They don't have to come to the city, and it obviously helps our researchers in terms of increasing their accrual to the trials.
So if you were to criticize your competitors who don't do that, what are they not doing right?
Well, they've alienated the community physicians in a lot of cases. There's this town gown thing that still exists in a lot of regions around the country where community oncologists don't want to refer to the academic center because typically they lose the patient. They never see the patient again. We make every effort to get that patient back to the community physician.
Right.
And so I think it makes a big difference in terms of referrals.
One more over here.
Hi, my name is Tracy Jackson. I'm from Pittsburgh Community Services Incorporated, and Precision Medicine has come to our organization and given a presentation. So we were not really aware of exactly what precision medicine would do, but I would like to know how much education you all would be willing to do to come out into the community, especially in the African American community that we serve.
Wonderful question.
So actually, this is Lynn's major task.
Lynn, stand up so they can actually know who you. There you are.
Maybe Lynn can comment.
So this is delegation, 3D.
This is exactly
live.
how
Yeah.
we find a lot of our niches, in all honesty. I'm out in the community with my staff, but many times it's events like this where someone stands up, so we need to get together and just put together what is needed. and we'll move on from there. I want to be in as many communities as possible. Currently, I do get into many, but there's many more to go.
And just before we wrap up, we'll come back. We'll have more. We're going to stay on this discussion for a while. But are you a data hoarder or a data sharer?
UPMC or me?
You can answer the way you'd like.
No, we actually collaborate with other cancer centers around the country. We actually have clinical trials.
I know Moffitt has been, we were in Tampa, and Moffitt is a very, very big kind of, I wouldn't call it national, but they've got it was very impressive to me how willing they were to share data with lots of other institutions. Is that something you're trying to achieve too?
Yes, and we participate in many of the national cooperative groups,
right.
Where the trials are, for example, NSABP, which is located right here in Pittsburgh for breast and colon cancer. We're one of the major participants of that. But when you're in a cooperative group, you share data. So.
Well, with that, I want to sort of thank you for your time here. I also want to share with the audience, I asked my team to find out something human about Dr. Marks. He said he saves pit bulls. I don't quite know what to do with that, but I wish your 3 pit bulls really well, and I'm impressed. Dr. Stanley Marks, thank you so much.
Thank you.